Shoulder instability. For the shoulder, the instability can be a symptomatic abnormal translation of humeral head. There can be static stabilizers and dynamic stabilizer. Static stabilizers is glenoid labrum fibrocartilage, articular surface which thickens at the periphery, the compression effect of glenohumeral osseous morphology, negative intra-articular pressure, and glenohumeral capsules. The glenohumeral capsules are superior glenohumeral ligament, which restrains for anterior translation at 0 degree of abduction, middle glenohumeral ligament, which avoids translation anterior posterior stability in 45 degree of abduction and external rotation, and inferior glenohumeral ligament, which has two bands and act as a hammock. Anterior band restrained from anterior translation at 0 degree abduction and external rotation, and posterior band which restrains from posterior subluxation at 90 degree of flexion and internal rotation. Dynamic stabilizer, rotator cuff, and long head of bicep. Third is proprioception, important in multidirectional instability. Regarding history, it happens in young patient, anterior dislocation with activities, especially abduction, flexion, and external rotation. Posterior dislocation happens with history of epilepsy. And regarding the instability, I need to check the trauma or atraumatic, first dislocation, frequency, and neurological symptoms, activity of daily livings like work, hobbies, and sports. Regarding, also need to know if there is a multidirectional instability, need to know the facioscapulohumeral dystrophy. Examine the patient, look, feel, move, quickly screen, do the Selkis test, anterior posterior drawer test, anterior and posterior apprehension, Job relocation test, and a Byton score. For a classification, Stanmore classification, traumatic structural, atraumatic structurals, and muscle patterning non-structurals. So traumatic structurals, atraumatic structurals, and muscle patterning. Other way around is Tubbs and Embry. Traumatic unidirectional Bankart is needed and surgery. Embry, atraumatic multidirectional bilateral rehabilitation and inferior capsular shift. Regarding traumatic unilateral Bankart dislocation, it's associated with ligaments injuries or tendon injuries. Investigation is axillary view. It's the best view to assess. Then Garth apical oblique view, which is 45 degree apical oblique view. MR arthrogram. Anterior posterior labral best seen on axial images. Bankart lesion appear as loss of triangular shape on contrast material leaking. An Eber MRI, abduction external rotation position, improved accuracy. CT arthrogram can be done for bony involvement. Regarding the Bankart lesion, is a soft tissue avulsion of anterior inferior labrum and anterior band of inferior glenohumeral ligament. Bony Bankart is if more than 25%, then it required bone graft and coracoid transfer. A Perthes lesion is a variation of Bankart lesion. Anterior inferior labrum is torn and lifted to the edge of the glenoid, but still attached to the intact lifted periosteum. Labrum may appear in normal at surgery, but functionally unstable. Needs to assess with CT and arthrogram. Some of the variants of Glenoid labral tear. A Bankart tear is when the labrum is torn. A bony Bankart is possible when there's a bony piece. Perthes is a periosteal stripping. Albsa is when it is medially displaced. GLAD is when there is a glenoid labrum articular defect and there is a cartilage loss. And there is something called GLOM, called glenoid labrum ovoid mouse.